Disparities in prostate cancer is a well-established problem, specifically disparities by race ethnicity. So when you look at population-level data in the United States, you can see from SEER data that Black men have a higher likelihood of developing the disease and dying from the disease. In fact, when you look at prostate cancer-specific mortality by race ethnicity, there's almost a twofold difference between Black and white men in terms of death. And so that's certainly a critical problem. But layered on top of that, we have the problem of underrepresentation in clinical trials. So when you look at our hallmark clinical trials, the ones that are defining our standard of care, less than 5% of those trials accrue Black men. When your target enrollments, if you want to achieve just representation in the United States, Black men make up approximately 12% of the US population. We know that we're certainly under accruing, and when you do that, there's a lot of implications. For one, you can miss a signal of efficacy if you have a sample that's inadequate. You can miss a signal of toxicity that could be life-changing for a patient. And so disparities in clinical trials is an important issue in prostate cancer disparities. On top of that, in prostate cancer research and treatment today, we have the rise of precision medicine with increased use of genomic testing, both somatic and germline or inherited genomics. We also have molecular imaging, flucyclovine PET and PSMA or prostate-specific membrane antigen, and these technologies are informing clinical trial eligibility. But one thing I'm concerned about is whether or not there's differential access to these technologies by race ethnicity and how that differential access may have downstream implications on clinical trials.